Good afternoon. My name is Melissa Rosales, and I will be doing my reading presentation on the article Healthcare Information Technology Vendors Hold Harmless Clause Implications for Patients and Clinicians. This article was written by Ross Koppel and David Kreda on March 2009. So I'll go ahead and get started on the presentation. I begin by including some information, a little bit of background on what a hold harmless clause is for vendors. It is a contractual legal structure that renders the vendors liability free. And what does this clause mean? It means that the contractual and legal device shifts liability and remedial burdens to physicians, nurses, hospitals, and healthcare professionals, even when facilities follow vendors' strict instructions. How do vendors achieve this? The vendors avoid liability by relying on legal doctrine known as learned intermediaries and on warranties prohibiting claims against their own product's fitness. According to this doctrine, HIT vendors are not responsible for errors their systems introduce in patient treatment because the healthcare professionals should be able to identify and correct any errors generated by software faults. HIT vendors claim that because they cannot practice medicine and are merely creating a software tool, clinicians are much more knowledgeable and stronger positions to identify those errors from resulting from faulty software hardware. The more HIT software embeds knowledge and performs complex calculations, the more risk there are to the patients. Without the hold harmless clause protection, innovation would be stifled and capital investments would suffer. Pharmaceutical and some medical device manufacturers have argued that because their products receive regulatory approval, manufacturers weren't responsible for errors. Hospitals and physician practices act alone and don't receive that much guidance from the Association of Physicians, guiding them and protecting them from software design and execution errors. Also, vendors retain company confidential knowledge about design faults, software operations, and glitches. Their counsel have crafted contractual terms that absolve them of any liability and other punitive strictures while compelling users non-disclosures of their system's problematic and even disastrous software faults. Implementations of HIT are massive, complex, and fraught with delays, errors, resistance, work, and redesign, process redesign, frustration, and failure. Hospitals and physicians have not engaged Congress to redress the counterproductive effects of their historic acceptance of the learned intermediary doctrine. So, what are some examples? Some examples are hospital leaders describe faulty vendor software that miscalculated intracranial pressures. If clinical decision support systems generate incorrect medication dosages because patient weights are misconstrued in an internal algorithm, and, for example, confusing kilograms to pounds. These are some examples of errors that have occurred in the vendor software, in faulty vendor software. So now we talk about customization. Some pros include modifications can improve the fit between HIT and workflow and enhance patient safety by tailoring menus and options to medical specialties. Some negatives, changes may alter presentation of critical information or connections within and among systems may have unforeseen consequences. For example, changing the background of the colors may conceal similarly colored text warnings may have critical results. Misuse. Unskilled users and those unfamiliar with the software's clinical application should not be vendors' responsibilities. Future changes. Many software specifics may not be enumerated in sales contracts and can be overlooked in arcane technical appendices. Vendors cannot predict all eventualities and cannot be held responsible. Some incentives. Vendors require funds to make changes and improvements to meet the user's requests. Broad product liability would force vendors to alter relations with users, which would modify supply and demand deliberations. Vendors fear that liability could lengthen innovation costs. Is there a mutual ground? Here are some several approaches that can be used between the vendor and the clinician, so responsibilities can be equal, and to encourage innovation while reducing the risk faced by patients. Again, here are several approaches. State and national organizations, through its certifications of CMS handbooks, conditions of participation, have the power to reset rules affecting contract terms. Clinicians and medical informaticians, medical professional organizations could declare that HIT contracts containing blanket hold harmless, learned intermediary clauses are inconsistent with professional practice. That would enable vendors to have further incentive to focus on patient safety concerns in addition to marketing prowess. And the American Health Lawyers Association, representing hospitals and healthcare institutions, has the expertise to write improved model contracts to delineate vendor responsibilities and liabilities. And in summary, excuse me, this article summarizes by stating that it is proper for HIT vendors to be held harmless for others' failures, or HIT vendors should be held harmless for others' failures. They should be held responsible for their own errors, which will bring incentives into balance and enable learned intermediaries to focus on patient care rather than on coping with product inadequacies or failures. And I did do a follow up on the article. There was an article written by Ross Koppel in 2019. It was a DePaul law review. The article was uses of the legal system that attenuate patient safety. And the article, the author mentions that since the publication of Koppel and Kreda article in the JAMA and the IOM and AMIA task force on vendor relations have urged the removal of hold harmless clause, calling it unethical and counter to the improvement of patient safety. And since then, he has stated that has the clause been removed and unlikely. So that pretty much summarizes the article for my presentation. The last slide is the references that I used, which is the article Hold Harmless Clause Implications for Patients and Clinicians, and also the follow-up article on uses of the legal system that attenuate patient safety. If anyone, if y'all have any questions, comments, please let me know. And thank you for taking the time to watch and listen to my presentation.